and ask him to make a few introductory remarks about himself and his practice. Thank you.
A small problem, I've given a number of lectures, but never without a lavalier. As a Mediterranean, I need to move around, so I don't think I can. So hopefully you guys will hear me. If I speak from here, can you guys hear me okay? No. Okay. So we'll give this a try. I've never done this. Jim and I discussed this, I think I don't know how many weeks ago, and this week I was in Los Angeles at the American Academy of Neurology meeting, and he sends me, which is due to run at the end of this week, and he sends me an email, what about your slides for tomorrow? There was a miscommunication. I get on a flight. I've been up since 4. I put the slides together, and I'm glad I'm here, despite my screw-up. This is a talk that I was going to give at Central DuPage Hospital. I am a neuropsychologist. I've worked for 15 years at an outpatient neurology clinic in Des Moines, Iowa. The last 4 years, I was mostly doing IMEs and then wanted to get back into the clinical world. So I'm out in Central DuPage with neurology, neurosurgery, and back into clinical neuropsychology. I think your organization asked Northwestern Medicine if they could give a talk. They gave my name, and I said, I'm not sure I can do this talk, but there are some others I can do. And so this is the talk that we're going to do today. And this talk was actually rejected by Northwestern. The actual title and the abstract. And I think maybe psychiatry has something to do with it, I don't know. But initially it was very enthusiastically received. But for whatever reason, this is how I got into this line of work. The person up there, Griffinstein, some of you may know the name. He's a neuropsychologist here in the Midwest. He's at Michigan, and he recently passed away. He's pretty well published, and somebody asked him to do a PTSD chapter, and he said, I don't have time, maybe Jim has time. So he and I wrote it, and it was well received. Manfred passed away a couple years ago, and it was very well received. It was published in one of our better known forensic neuropsychology texts. And then another person asked me to write the assessment of PTSD, which is strictly clinical, and that just came out. And then I'm going to be doing another one this year. So this whole thing is expertise by default. I don't know that I have any more or less experience than anybody else, but I think I've read this stuff pretty thoroughly and kind of thought about what's important and what may not be important. So, I'm a historian. Harry Truman's quote, the only thing new in the world is the history you don't know. And you pick up the DSM and you just automatically assume that there was some rational way that all those disorders appeared in there. And it's not always rational. This is the history of PTSD. This is a fantastic book. And it tells you exactly how PTSD came into being. And in terms of the skeptics and the enthusiasts, as it comes to a lot of these issues, these are the enthusiasts who wrote this book. And I'm more of a skeptic. It's a great book, and I want to go over some of this history of PTSD with you. This is from another book, and I'm just going to read the quote. I will argue that this generally accepted picture of PTSD and the traumatic memory that it underlies it is mistaken. The disorder is not timeless, nor does it possess an intrinsic unity. Rather, it is glued together by the practices, technologies, and narratives with which it is diagnosed, studied, treated, and represented, and by the various interests, institutions, and moral arguments that mobilize these efforts and resources. What they're saying here is, can everybody hear me now? No. What they're saying here is PTSD is real. If you're in combat, if you've been raped, these things happen. But the term PTSD was coined, and it was coined as a direct result of an event. the Vietnam War. Without it, it wouldn't have happened. These are people that invented it. Again, stress syndrome is real, PTSD was coined. And these are the people that did it. Shatan was a psychoanalyst at NYU. Robert Lifton was he was at, I believe at the time, Harvard, and now I think he is at, he was at Columbia, and now he's also at NYU. Sarah Haley was a social worker at the Boston VA. Marty Horowitz is the father of modern stress studies. He was at UCLA at the time. And Charles Figley founded the International Society of Traumatic Stress Studies, those people that study traumatic stress. And these people together, what was more advocacy than science, got the term to get into the DSM. Lifton wrote a book, Home from the War, Vietnam Veterans. Haley wrote a very influential paper about what the veterans were going through when they came back, very often cited. Horowitz I put in there because the book is classic, and it still is, in terms of stress syndrome. And then the last one, Figley, is an important one because I have some quotes from Figley. Charles Figley really wrote the first summary of PTSD for veterans as they were coming back. And I ordered that book online, and it's quite interesting. This is the medical journal of record, whether it's medicine, psychology, psychiatry, the lay public. This is how things get done nowadays. In 1971, this paper was, this article was published in the New York Times, and it was about a Medal of Honor winner who, after he got back from Vietnam, was involved in a robbery and then was killed. And basically the upshot was that a lot of what he went through, including the robbery and being killed, was as a result of Vietnam. This set the groundwork then for a lot of the people that I mentioned earlier to write their own paper. This by Shatan was written in the New York Times in 1972. He sent it to him a number of times during the course of the Vietnam War, but they declined it. It was only after that first article that they accepted it. And in this article, Shatan, a psychiatrist, a psychoanalyst, anti-war, and again, this has nothing to do with politics in the sense that, you know, as a psychologist, we're generally liberals. I'm generally liberal. So if I were at that time period, I don't know if I would have joined them, would I have been in Canada? You know, I don't know. But he, of course, was against the war, and he wrote a paper about the post-Vietnam syndrome and described some things that were previously not described in terms of stress. And the details of that paper eventually found their way into the DSM in terms of how PTSD was described. Now, of course, the New York Times is still at it. This is a hot topic, as you all know. This is the article that started the concussion, chronic traumatic encephalopathy issue, and it's 10 years now that we're into it. So this is, if PTSD is the biggest, it is the biggest, it has had the biggest impact in psychiatry in terms of any diagnosis. And I think this may trump it. I was supposed to be at the meeting today to listen to Dr. Omalu talk, the concussion movie person, Will Smith, but I'm here today instead. Without going to this topic, if you Google my name, the word concussion and CTE, you might read some interesting things. I've written a number of letters and responses to what's going on there. All of science is separated into two groups of people, the skeptics and the enthusiasts. This is a paper that I read 3 or 4 years out of school. So I was in '89, I got out of school and read this. And basically, you know, the skeptics say, no, you have to really confirm that there's a seizure. The patient can't subjectively tell you that they feel funny or there's some alteration of consciousness. Mild head injury, everybody knows there's a skeptics and enthusiast debate there. adults presenting with ADHD. If you didn't have it as a kid, then you don't have it as an adult. So that's the skeptic speaking. Pain. That is also very complex regional pain syndrome. That's also controversial. Rehabilitative therapies. Does cognitive rehabilitation actually work? Meaning if you have brain damage and you go to therapy, is that going to help you? So, and PTSD falls along the same lines as the skeptics and the enthusiasts. So I cited some of the enthusiasts. When I bought that book, the Marty Horowitz book, inside, oh, I'm sorry, this was a book by Charles Figley. Inside the cover of that book, I found this. It was completely random. And you can see what it says. I don't know who Tim Remick is. A friend and a brother and a true believer. And a believer is that they were trying to do something at the time, and that is to get PTSD on the map. So, and that is Charles Figley's signature. As the enthusiasts were talking about PTSD, then there were the skeptics at the time. The skeptics came from WashU. They were doing studies. These were the studies they were doing. And the studies essentially showed there are some problems. There is some drug use. There is some depression. There is some anxiety, some alcohol use, but a lot of it was self-limited. And all of these, they had these studies to present. And there was nothing really unique necessarily in their minds about Vietnam. And then they did a seminal study in the New England Journal of Medicine, which essentially said this: if you're going to get PTSD and you're a veteran, you're generally going to be wounded to get the diagnosis. And this is the prevalence rate of PTSD. 4% of those in combat are not wounded, 4% met the diagnosis. And generally you had to be wounded. You had to be in the thick of the fight to get the diagnosis. So they did not find that it was very common. The very next year, in 1988, JAMA published another epidemiological study, essentially the same statistics. These were representative studies of the population at large, this one including veterans. So the debate began. It exists, but it is PTSD. It is uncommon except among wounded veterans. The symptoms were usually few and seldom excluded features that were claimed to be the hallmarks of post-traumatic stress disorder. One of the hallmarks was flashbacks. Flashback as a symptom did not exist prior to this. The idea that you would relive it actually at that moment. The issue of the long delayed onset, and that has a lot of legal implications. We'll talk about that. Recurring and emotional numbing. The common symptoms were hyper-alertness, sleep problems, and nightmares. So the debate raged immediately, and this was the response. The article in the New England Journal of Medicine said, you know, a lot of this is politics. The response from the National Center of PTSD, which now exists in Boston, and really defines a lot of the practice of PTSD. This is Terry Keene, who's the head psychologist and has been there essentially forever. We believe that PTSD is not a de novo diagnosis whose interest in the DSM was politically motivated, but rather a serious psychiatric condition affecting many men and women who have survived life-threatening events, including combat, rape, political torture, and other disasters that often occur in the course of world events. Its effects should not be minimized. So the enthusiasts now had to do their own study to counteract the New England Journal and JAMA, and they did this study in opposition to the skeptics. The problem with this study is that it appeared in a book. So a book is not the same thing as a peer-reviewed journal, certainly not JAMA and New England Journal of Medicine. This is the book. This is an edited book. A lot of famous, well-known people wrote quite a bit about PTSD in this book. You can see, though, that the numbers now are significantly higher for PTSD than was previously the case. And if you read some of the things in the book, this is one of them. This is from Sarah Haley in the book. The only report that should not be accepted at face value, although one may choose not to challenge it, is the patient's report that combat in Vietnam had no effect on him. Now, I don't know if that's very good to a way of approaching a patient. It's almost insisting that it must have had an effect. And a lot of people go to war, and war does not affect them, they go back. This is the editorial note by Charles Figley, the founder of the International Society for Traumatic Stress Studies. This is the sort of epilogue. Perhaps when next confronted with the prospect of sending citizens to fight in a war, the purpose of which is questionable, policymakers will consider these findings. Perhaps it will be moved to acknowledge the vast and enduring cost of such a war on an entire generation of this country's children, perhaps. So it is a politically loaded discussion at the time, and it remains politically loaded as we go into DSM. DSM is very controversial. I think at this point going forward, DSM is a historical document, at least for me. There is a person by the name of Alan Francis, emeritus at Duke, who chaired DSM-4, and he wrote a nice book called Safety Normal, in criticism of the most recent DSM. And he essentially says, is there any behavior anymore that's normal? Because when DSM started out, it was this thin, and now it's 500 pages. And we're not talking genetics, we're talking phenotype, right? So it's something that you recognize, you see. Have we really seen that many more diagnoses? This is the definition of PTSD, as defined in DSM-1. In 1952, that was the first DSM. And why in 1952? Because it was after the war, World War II. A lot of veterans came back with a lot of trauma. The government says, who's going to help them? Psychiatry? Well, how many psychiatrists do we have? We don't have many. Is there anybody else that can help them? Psychology, what do? They do rat experiments, and they know a little bit about behavior. Well, can we get them to learn about clinical things? And they all met in Boulder in the 40s and founded clinical psychology. And that's how we got started. PTSD, the way it was initially understood was you had to have an experience that was outside the realm of everyday human experience. Torture, rape, and combat are not things that are commonly experienced. And that's what PTSD was in DSM-1. In DSM-2, it completely disappeared. There was no mention of any stress disorder in 2. And then you have to kind of wonder, and that was in 68, DSM. And now we move to DSM-3. And so DSM-3 is really what defined PTSD for us in the modern era. PTSD was coined for DSM-3. The term didn't exist. They wanted to call it post-Vietnam syndrome. But the skeptic said, you know, I don't know if that applies to a woman that was raped. So I think we're going to go with the PTSD, and that's what they went with. These are the core criteria for PTSD. The important thing is those things that are highlighted in italics are non-specific to PTSD. That's a very important thing to remember. What are the core features, and what are the sort of allied or ancillary features? And so what was important about DSM-3 is they said it had to be outside the realm of everyday human experience. A dog bite doesn't count. A fender bender doesn't count. And so then we go to DSM-4. Alan Francis, the person who's currently criticizing DSM-5, the professor emeritus from Duke. He is the one that removed the criteria from DSM-4. It didn't have to be outside the realm of human experience anymore. So now, the skeptics are saying you're watering it down. This is Nancy Andreessen. The enthusiasts that I talked about earlier were in constant contact with Dr. Andreessen. She is professor emeritus at the University of Iowa. She was a young psychiatrist in the 70s, and she was told that you're going to be on the task force that defines this new disorder, PTSD. So it was Nancy Andreessen that wrote the whole section for DSM-3. So she's responsible for it. And this is what she had to say, outside the range of human experience, because it's now been removed. In my view, this broadly should be reconsidered, giving the same diagnosis to a breast cancer survivor and someone who's a motor vehicle accident diminishes the magnitude of the stressor and the significance of PTSD. Can we fix DSM-5? The psychiatrists are not interested in it. Internationally, people are going to be going to ICD-11. The American Psychological Association is critical of it. And there's a number of reasons, without getting into all of them. But without getting into this, you can all look it up. We went from 17 core symptoms from DSM-3 to like 24 now. Okay? This description now is completely different than what the International Classification of Diseases is proposing. There was going to be a harmonization by which both DSM and ICD were going to come up with the same criteria, work together. That is no longer possible. And a lot of these things, without getting into the details, never appeared in DSM. For example, negative alterations in cognition and mood. That wasn't there. A lot of the new criteria is describing veterans. And a lot of the new criteria, when you read it and you say to yourself, well, how does that apply to the case of rape? So, what has changed in DSM-5? DSM-5 now has stress section of its own. Stress section versus a mood section versus a psychotic section. Before, PTSD was in the anxiety section, where it belongs. Remember from undergrad, classical conditioning, you hear the dog hearing the bell. Was that opera? I can't remember now, it's been so long. Pavlov for sure, but I can't remember if it's operant or classical. Basically, it is a physiological reaction, in the case of the dog, to the bell, as is PTSD, a physiological reaction to an event that happened to you that was traumatic. And when you re-experience in some way, you have that reaction. And so it is an anxiety disorder. It doesn't necessarily have to go in its own section. Malingering should be ruled out. It was in previous DSMs. It's not in the present. Somehow they put traumatic brain injury in there. So as you're working up PTSD, rule out traumatic brain injury. Well, without getting into that in much detail, that again is focusing on veterans versus everyday PTSD. And this is the ICD-11 classification system. By the way, all of these slides, don't worry about writing anything down, they'll be available for distribution afterwards. And then there's an email address at the end, you can always email me. This is the ICD-11. Robert Spitzer revolutionized the DSM in DSM-3. He made them research criteria. They were bulleted. Okay, for the first time, you could actually go and read which of these symptoms are met versus prior DSMs where there was a description. Okay? And what Spitzer said, the father really of PTSD, as it was described in 3, he was the father because he chaired DSM-3. He said, you know what we ought to do with PTSD? Let's concentrate on the core symptoms. Sleep, memory problems, attention problems. These don't have to do with PTSD. Yes, PTSD patients have them, but they don't define the disorder. So this is what he suggested, and this is what the International Classification of Diseases is going to do. There are 3 core symptoms: re-experiencing, avoidance, and hyperarousal. That's it. Very simple. And so when I do a PTSD evaluation, this is what I do. I go with ICD-10. It's international. Somebody would say, well, what about DSM? I would say, well, you know, I'm not a psychiatrist. That would, and then try to provide as much evidence for why DSM should not be used. The thing with ICD, it has always maintained that you have to have an experience outside the realm of everyday human experience. Because in the world, in the rest of the world, there's war, there's famine, there's torture, right? And so they have a different sociological perspective on how it should be viewed. And that's always been in there. And I think it's going to remain in ICD-11 once it's published. Very interesting. This follows the outline or the perspective of Marty Horowitz and how he viewed PTSD. This is the first PTSD scale, okay? Horowitz had intrusions and avoidance as the core features. The scale became revised much later when they added hyperarousal. Okay, so I think the skeptics and the enthusiasts are hopefully aligning. And hopefully this will be the definition. Nothing riles people involved in this area than delayed PTSD. This is what Shatan wrote back in the 70s. These meetings were initiated in the 1970s. The meetings were Vietnam vet rap groups. Psychotherapy that was conducted by Shatan, Lofton, Haley. They were conducted everywhere throughout the U.S. Berkeley by Horowitz. Because of their distrust of the establishment's psychiatric services or because their disturbance manifested themselves too late to provide the service connection required for Vietnam administration treatment. So basically, they were arguing back then, we need to have delayed PTSD. The question is why? And you have to admire him for his honesty. This is why. What if the veteran were to claim at some later point and you were to artificially cut it off at a certain time period? And Marty Horowitz said the same thing. We need to have a delayed PTSD. So DSM-5, it made it into DSM-5, delayed PTSD. In ICD-11, PTSD, delayed PTSD is considered to be rare. It's very simple. Somebody is raped today, and 7 months later they develop PTSD. What is the rationale? Clinically. So in order to get it into the new DSM, you have to do a bunch of studies. So we had enthusiasts back then, we have enthusiasts now. This was a study done in Australia by probably one of the most preeminent people in Australia with regard to PTSD. They did this study and basically found, and there was a bunch of other studies that were done. These studies have implications for DSM-5. First, they suggest that delayed PTSD is a relatively common condition that needs to be adequately represented in the diagnostic nomenclature. So now it is in DSM-5. The very last sentence of that article, the last paragraph, As the focus turns to DSM-5 and as the implications of delayed onset become increasingly important for veteran and civilian health and compensation systems, it is vital that the research continues to better understand these complex trajectories of psychopathology after the trauma exposure. So there is at least some intellectual honesty there that there is another issue as it relates to delayed PTSD, and that is compensation and when you can get it. This is the most famous PTSD case, delayed PTSD. She made the claim long after the fact. The judge read it, and he threw it out. What does Nancy Andreessen have to say? Many soldiers do not develop stress symptoms until they return home, since a stress reaction in the midst of combat is not adaptive, and so the impact of their traumatic experience is delayed. Therefore, we also defined a delayed form. They did this in DSM-3 because the PTSD is not when you're in combat or the next day or the next week or the next month, okay? It's okay if it's 3 or 4 or 5 months later, but when it's years later, that makes no sense. And so Andreessen didn't anticipate that this would happen. So this is, I was going to say this is Bill Clinton thanking Nancy Andreessen for saying that, but as it turns out, Nancy Andreessen won the National Medal of Science for her work not in PTSD but in schizophrenia. So no, he's not thanking her. This is PTSD. It's very consistent. These are not cherry-picked. These are consecutive, enrolled people in the best of the best journals, in truly traumatic experiences. 9/11 is a little bit less because we're involving people in the New York, in the vicinity around Ground Zero, not necessarily those in Ground Zero. So that's why that might be a little bit less. But if you have truly a traumatic experience, 1/3 of those people are going to get PTSD. But these are truly traumatic events. As opposed to this, published by the American Psychological Association, APA, down at the bottom. These are people seeking treatment after a motor vehicle accident. Over half are in litigation. The CAPS is the gold standard for the diagnosis of PTSD. It's a structured interview, and that's a high score. 68% of these patients have PTSD. So we have a motor vehicle accident, and then we have Rwanda. Twice as many have PTSD as a result of the motor vehicle accident. And at least they were honest about what they did or did not do. And the book was called After the Crash. Participants were asked if they contacted a lawyer. If they answered affirmatively, they were scored as involved in litigation. Now, you don't have to have a lawyer for the injury to be compensable. If you fell at Walmart, it doesn't matter whether you have a lawyer or not. So that's one message for that. We made no effort to check the veracity of the people's symptoms. But we have no reason to doubt them. In our larger sample of 400 participants, only 2 were believed to be exaggerating. We did not use the MMPI. We did not collect medical records. So this is a whole book devoted to now we take head injury and we move it to another country, other countries. This is the prevalence of PTSD when you're involved in a motor vehicle accident. Again, these are not cherry-picked, these are consecutive cases, these are different countries. Okay, the one at the bottom is very interesting. It was done in Germany where the parent and the child were in a car. And whether PTSD developed in the mother or the father. And you can see it here out. You know, who still had PTSD in terms of mom and dad? It's very uncommon to have PTSD as a result of a fender bender. And if you're in a coma, you haven't witnessed the event. So that's the other thing about PTSD. You have to be in the moment. Now, we're going to call this the M word, for lack of a better definition. I think the only way to really understand this is that it occurs, okay, in all walks of life. And it occurs in the clinic. Let's forget about where we are at the moment and discussing it outside of this context. The clinical that you see, there are 52 consecutive clinically referred mild head injured patients referred by neurologists who reported worsening or non-improving post-traumatic headache. Is everybody with me for the clinical? You can see their age, their age, the breakdown there. The legal is 50 consecutive, the first 50 referred to me by defense for a mild head injury. Two different populations in terms of the referral source. The important thing to remember, both were given the same battery, and look at the percentage of impaired scores. Out of 29 scores, the clinical group failed 6 tests, and the legal group failed 7, which is not statistically significant. The last group that you see there, 24 patients, are 24 patients that I personally examined in an inpatient unit following a severe head injury, which is a Glasgow scale of 8 or less. You can see that you can't have the same number of defective scores if you have a Glasgow scale of 8 versus a Glasgow scale of 15. These are their test results. So, in the clinical world, I see a lot of Alzheimer's patients. I've seen probably 1,000 in 25 years. We saw 250 patients referred to a Alzheimer's disease registry. Okay, that is, if you're 55 and over, you're enrolled in this registry where you're assessed for Alzheimer's disease. Those that were in the pre-senile group, that is, they were younger than the age of 65, Alzheimer's disease happens, but it's not very common. We found 6 people who are younger than 65 out of those 250 who had Alzheimer's disease. And you can see the rest of the breakdown there. But there were also 5 that were malingering. Before the age of 65, you still have to work. Now that's my diagnosis. Whether it's true or not, we don't know. But it does occur in the clinical population. When the economy went belly up here, I think it was in 2008 here in the U.S., when we had the downturn, economic downturn, we would get more Social Security disability applications in 1 week than we would get the whole month prior to the downturn. This is the patient filling out the MMPI. The MMPI-2 has 10 basic scales. Number 1 is the hypochondriasis, 2 is depression, 3 is hysteria, 7 is psychasthenia, which is anxiety, 8 is schizophrenia. I've included only those scales that were significant for all of the groups. In the first column, you have spinal cord injury. 42 consecutive patients with spinal cord injury. Now again, when you pick these in the literature, you're looking for consecutively examined patients. As a group now, they had 1 elevation in the hypochondriasis scale. Well, they actually have a spinal cord injury. So if you actually have a spinal cord injury and there's numbing, that's not hypochondriasis. Okay, so we have to keep in mind that some of these neurological patients, there's going to be elevations because you have neurological symptoms. In the second column is headache patients from a headache clinic. That's their only elevation. In the third column, HI, severely head injured patients. Severely head injured patients consecutively admitted to an inpatient unit, their mean scores as a group are normal. That's not to say they don't have individually impaired scores. Seizure patients, you have diagnosed bona fide seizures, 100 consecutive patients, completely normal MMPI as a group. If you're making up seizures, pseudo-seizures, the PZ, you can see what's elevated there. And these are people with psychological issues. There's factitious disorder, in which I have to make up symptoms to get attention to meet a psychological need, and there's malingering that's completely different. And then those mild head injury patients that you see in the second to last column are all mine, consecutively seen over however many years. And you can see the elevations there. Mild head injury, Glasgow Coma Scale less than 13. And the last column is another group of patients that we see. 1/3 of patients that go into a neurology clinic have nothing wrong with them neurologically. Sir, we can't explain your numbing, we can't explain your pain, we can't explain this double vision. That's how things are. And what these patients have, these are just run-of-the-mill patients, what we call them the worried well. And these are their elevations on the MMPI. Okay, so the last group is the psych group. Strictly psychiatric, there's no compensation issue. So that's 1/3 of outpatient neurology. So then we're talking psychiatry. That's one claim that people are making that's sometimes difficult to prove. This is pretty straightforward. It's important to remember that when it's pretty straightforward, litigation context impacts the situation. This was done in JAMA. This was a meta-analysis. They just basically took all the studies in which surgery was performed and in which they stated the compensation status, whether it was work comp. And compensation status results in a generally worse outcome. So it's just not for psychological conditions. Malingered PTSD. This is kind of callous, but Nancy Andreasen said it. And we know why this is the case. It is incident specific. If you're going to make a claim of PTSD, you have to tie it to a trauma. No other psychiatric disorder has that, only PTSD, and that's why it's frequently used. These are 3 patients I saw. How much time do I have here? What's that? 50 more minutes. Okay. These are 3 patients I saw in May of 2007, in 3 different cities within Iowa. The red one, I can't remember which the red one is, it's one of these 2. One of the people, either the red or the green, was driving a semi-truck on the highway with his wife sitting next to him, and he saw a car coming at him. He tried to pull to the side of the road, but the car kept coming at him, a small car, and speed increased, and it rammed him. And that was a suicide attempt by the driver of the other car. He barely got out of that. It was his wife who had the wherewithal to unbuckle his seatbelt before the cab went into flames. The second person works at one of the city parks, and the sun caught him in the eye, and as he was making a turn, his car caught a jogger and killed him. And he had a previous psych history, so he spent some time in inpatient unit. All the scores that you see there are the scores on a self-report instrument of PTSD. And where you see the spike at the beginning, it's the amount of trauma that's experienced at the moment for those 2 patients. Okay? PTSD is Peritraumatic Stress Disorder, the trauma that you're experiencing right at the moment. And the rest are different scales: substance abuse, suicide, impulsiveness, hyperarousal. The person in yellow is the 3rd person I happened to see that same week. She jammed her finger in the door at work. And that's her test result relative to the other two. And that isn't proportionate. The International Society for Traumatic Stress Studies says you have to rule out malingering. If you want to study a condition and you want to know the true outcome of that condition, you have to account for other factors that affect that outcome. And so for the first time, they put that in DSM, in their practice guidelines. So on the one hand, you have people that are super conscious of diagnosing malingering and talking about malingering and my malingering test this and my malingering test that. And it is the single most commonly researched thing in neuropsychology if you go into the journals in neuropsychology. But it's had a very negative impact, and we wrote this in the book back in 2005, Manfred and I. There appears to be an inverse relationship between the enthusiasm an individual has for symptom-validity testing and their knowledge of the syndrome. When the doctor calls your patient a malingerer, no matter what the case is, you know, doctor, you know what? I don't know anything about these symptom-validity testing, but this is a condition my patient has. Why don't you tell me a little bit about it instead of giving me your cutoff score? Between the enthusiasm an individual has for symptom validity testing, the malingering, and their knowledge of the syndrome they are trying to refute with symptom validity testing. When there's a diagnostic uncertainty about a case, the rapidity with which the neuropsychologist asks the obligatory, where's the symptom validity testing scores, can be embarrassing at times. One has to question if symptom validity testing, malingering testing, has dumbed us down. We belong on listservs. We discuss cases, stroke, Alzheimer's. You know, those patients see disabilities too, and the first thing you see, what was their symptom validity score? You know, and it's truly actually mind-numbing. Because a lot, I don't see a lot of patients. Case consultation. This, we're going to go through very quickly. This is going to be in your handout. This is going to be what you should be doing if you have a PTSD case. We're going to go through this very quickly so I can get some time for some questions. So it's best, an IME is best, don't worry about copying it, you'll get a copy. It's best done by a psychologist for what reason? Because we test, we give tests, we give the MMPI. It should be an event that's outside the realm of human experience. If therapy has failed, you should get an IME. If the PTSD symptoms appear 1 month after the event, it's best to start with an evaluation right off the bat. If the patient's not complying, you should get an IME. If the patient's not back to work after the first cycle, get an IME. If there was no improvement after 3 months, treater unwilling to commit to a treatment timeline. The gold standard for treatment of PTSD is cognitive behavioral therapy, which is time limited. It's not analysis. And then the treater assuming the role of an expert witness. General considerations, managing the claim. The patient has the right to choose their treater, okay? Because we want them, the company does not have that right. Medication could be started by the primary care doctor, even though the gold standard is therapy. Request a timeline for treatment. If no improvement, refer to a psychiatrist for the medication. Request monthly updates. Do not ask the treater if the patient's malingering. Their job is to help the patient, okay? But then again, do not ask the other flip side of that is you're asking the treater to make all kinds of inferences and they don't have the entirety of the medical record. If workers not complying with treatment, get an IME. If no improvement in 3 months, get the IME. I think I might have said some of these. Let's see here. Let me skip to, sometimes it's good to wait a month. It's good to wait a month because just because a person has been in a trauma does not mean they develop PTSD, okay? So the thing about it is if somebody has a truly horrific event, do you say to them, let's get you in therapy right away? Okay, because at that point, are you making the patient worse? Or are they going to naturally recover? So keep that in mind. Here are some other things. And all of this is in your handout. A lot of these are, and then also some mistakes with regard to PTSD. The event is not of sufficient severity. People rely strictly on self-report. They don't give personality testing. They list the symptoms of PTSD, but not a single example, okay? They bean count the symptoms. Which of the 17 symptoms did you have without characterizing them? A neurologist doesn't say you have tremor, yes, no. When did you have it? Is it resting? Is it in tension? Do you have anything else with it? What medications are you on? Same with PTSD. Assuming an advocacy versus a scientific role, failing to ask about all the symptoms. 90% of the time when you look at a medical record, people have not asked about all the symptoms of PTSD. You have flashbacks, you have dreams, but never do you see all of them listed. Let me leave it at that, and let's, that's the email. Like I said, I will provide this copy, and then I don't know what the best way is to distribute it. Let me go ahead and take some questions. You're going to have to speak loud because I can't hear you. Right there?
Why did Northwestern reject this presentation?
You know what? I have it. I have it right here. The description. It was well accepted by the person that was coordinating it. And after about 3 or 4 weeks later, I said, you know what? That's not going to work. And I don't know why. Because the same presentation I was going to give to them, and I think it had to do with psychiatry and the divisiveness of the issue. And I think that's reasonable, you know. So I'm talking about depression and neurological disease and the psychogenic patient instead. So, fair enough.
One more question.
Yeah.
So I was a little disturbed by your presentation that seemed to indicate that the recognition of this condition began after the Vietnam War, because I think it's fairly well known that clinically they've known of this condition since at least World War I, shell shock. Dr. Roy Brinker of the Psychoanalytic Institute in Chicago wrote about post-World War II because he served in the war personally.
Let me interrupt you. What was invented was the term PTSD. My file on the computer, and I'd be glad to share with you, scores and scores of articles on, it used to be called rape syndrome, and prior to 1980, Holocaust survivors. It's clearly described in the literature. So let's be clear on that. We're just talking how PTSD was coined. To say that it didn't exist is ridiculous. Back there?
Yes, I would like your opinion on what I'm seeing a little bit more of now is prescriptions for medical marijuana to treat post-traumatic stress disorder. What are your thoughts on that?
I spent 5 years in pharma and medical affairs, and if they're not a randomized trial, then it doesn't exist. And I don't have any expertise on that topic, so I can't say. But unless barring a randomized, and even if there was a randomized trial, in our clinic in neurology, we will treat your pain, but you will get no narcotics. That's one approach. Oh, I'm sorry. So the question was about medical marijuana to treat PTSD,
Yes.
and the answer is no.
The answer is no, that you don't believe in that as
Correct.
necessary or required treatment.
Right. I mean, the gold standard is cognitive behavioral therapy followed by medication.
Do you believe PTSD itself can be cured?
Oh, sure it can.
And how do you do that?
I have a study here in the case of rape. Oh, I'm sorry. How do you cure PTSD? Just like you cure any psychiatric disorder. Some psychiatric disorders, schizophrenia, bipolar, that's one thing. PTSD is another thing. There's natural recovery. So in the case of rape, after the rape, within a year after I can't remember if it's 6 months or a year, it's 50% that still have it. And it continues to decline after that. So In the case of the two people that I showed you, with one with the car being rammed into and the other person who killed the other person, this is not something that you want to think about forever. This is something you want to move on. And so when you're suffering, and you know, I see people with mangled hands and arms, and I mean, I get PTSD just looking at it. This is not something they want to continue. They want to move on. Yes?
If there's no trauma, if, let's say you're a clerk in a store and some guy comes in and puts a gun to your head and, you know, and robs you, but there's no physical trauma, can PTSD result from that?
Yes. In the book, that one of the chapters that I wrote, trauma is frequent. So I give an example of myself. I was held up with a gun. I escaped the fire with only my computer. I was actually mugged because I was raised in the inner city of Chicago. Okay? All of these 6 or 7 traumatic things happened to me. I avoided those neighborhoods, so I had avoidance for some period of time, but I never sought treatment. So I mean, you can, because the issue is you don't have to be struck or hit. There could be a danger right then and there present, and when somebody's pointing a gun to you, I've had it happen. So, other questions? One more?
Does that include observing trauma in others?
Yes. I mean, if you see somebody being tortured, yes.
How do you determine that an event is sufficiently severe?
Excellent, excellent. I don't have the slide on that. How do you determine if the event is severe? And that's a very good question. There's a nice article by somebody who simply said that the best way to do that, God, I don't have the quote handy. The only way, I guess, to do that, it is a wonderful quote, is in some of the research, there are about a dozen things that are identified as what they call legitimate stressors. And that's, I mean, the best thing to do in my mind is let's agree what's a legitimate stressor without showing you all the slides. Any other questions?
If the problem is the person having an abnormal response to the stressor, why are we focusing on the quality of the stressor? Shouldn't we be focusing on the person's response to it? Why do you need a certain kind of stressor?
The original PTSD diagnosis was not that. It was an experience outside the realm of human experience, as is ICD-10. Because it essentially trivializes it. Now, that's an adjustment reaction, right? I mean, we're not denying the stressor, but there's a difference between a stressor, an adjustment disorder, and depression and anxiety from that stressor, and saying that a day doesn't go by where you don't think about it indefinitely. So that's the difference. Nobody's denying the trauma, and nobody's denying you can have a psychological reaction, but not PTSD if it's outside that realm. Okay, out of time. Thank you.